Just to give you a bit of a background, Dr. Fabian Ahumada had emailed me about a patient with ALL, and it was difficult to give all the details of the new research because, as you know, the research in ALL is moving rapidly. So it's important to update it in frequent formats so that perhaps your group could look at the results and maybe start implementing some of them in your practice. So as you know, the treatment of ALL for the past 60 years has been the same. It's intensive chemotherapy given over 3 years. And in childhood ALL on the left side, this has led to a cure rate of over 80%. In adult ALL, the blue curve shows that we were stuck up till 2010 with a 5-year survival of about 50%. And this includes all age groups, under 60 and over 60. Now, since then, at MD Anderson, we have designed new things since 2010. And I'll show you that even the red curve is very pessimistic. I'll show you that, in fact, we have results with 4-year survival of about 80%. So if the treatment has been very successful, and that's why the pediatric ALL experts are not willing to change quickly, why do we need to change this successful intensive chemotherapy? I think it should rest in peace because it has served us for 60 years as a good paradigm of treatment, but there's too much chemotherapy given for too long. And while this is manageable in leukemia centers, in cancer centers, when you go to the community practice in rural areas, in emerging nations, among the poor, this regimen is difficult to deliver. So the question is, can we develop shorter, less intensive chemotherapy regimens that could incorporate more effective treatments such as ponatinib, blinatumomab in Philadelphia-positive ALL, and blinatumomab and inotuzumab in pre-BALL. And in time, they will be available and affordable to all. So rather than stick 3 years of therapy, I'll show you at the end that we have designed in a pilot trial a regimen that has 7 months of therapy, which looks very good. So what should we incorporate? In Philadelphia-positive ALL, I'll show you the data with ponatinib, blinatumomab. And there are some new, safer BCR-ABL inhibitors like olverembatinib. In pre-BALL, we are relying on the new antibodies that target CD19, like the bispecific T-cell engager blinatumomab and the antibody-drug conjugate inotuzumab. I'll show you that we're starting to use CAR T cells not for active relapse, but in consolidation instead of allogeneic transplant. And I'll show you some data from the ASH meeting. And it's very important to start tracking disease now by the NGS clonoSEQ for the immunoglobulin heavy chain, because it analyzes about 1 to 3 million cells. And this way, even when you have very little disease, you can consider changing therapy or even discussing the duration of therapy. So my goal, the goal of the leukemia program at MD Anderson, is that maybe 5 years from now, we will present enough data on what I refer to as the dose-dense mini-CVD inoblina, with or without CAR T cells, a 7-month regimen that could be as effective as what we're doing now in our practice. Now, in all our studies, we have stayed with the hyper-CVAD or its modifications. We developed this in 1992, and we made several modifications. In 2006, we started using pediatric-inspired regimen because of the pressure to use them in the adolescent young adults. And the results were similar in our hands to the hyper-CVAD. Now, the hyper-CVAD is more intensive, and when it was used in France, in a cooperative group, the induction mortality was 10%. So you have to use it with experience. In 2012, we went back to the hyper-CVAD, and this is the regimen that can be used across all age groups with those adjustments, as I'll show you. But I think the discussion of hyper-CVAD versus pediatric is obsolete today because both these regimens have to reduce the intensity and duration of chemotherapy in order to be able to incorporate the new treatments. So this is the data that we published comparing hyper-CVAD to the augmented BFM. This is in the adolescent young adults, and the 5-year survival is 60%. It's identical in both regimens. So first, I'm going to discuss Philadelphia positive ALL. And as you know, up till 2000, this disease we could get in a complete remission with intensive chemotherapy at a rate of about 80%. But unless you could go to transplant, the patients were going to die. So it was a death sentence. If they had a transplant, as shown by the French, the cure rate was about 35%. There were 2 inflection points in Philadelphia positive ALL treatment. The first one was in 2000 when we started incorporating the first BCR-ABL kinase inhibitor, imatinib, into hyper-CVAD. We later replaced it in 2006 with the more potent dasatinib, and in 2010 with even the more potent ponatinib. Patients were living longer, so we started seeing CNS leukemia. We increased the intrathecals to 12. And we started using allogeneic transplant less commonly. The second therapeutic inflection point came in 2017 when showing that blinatumomab was as effective as intensive chemotherapy. We took the risk at MD Anderson to remove all the chemotherapy and replace it with blinatumomab with ponatinib, because we removed the methotrexate high-dose Ara-C, which had served as a systemic high-dose chemotherapy for CNS prophylaxis. We increased the intrathecals to 12, and we started transplanting only patients who were NGS MRD positive after 3 months of therapy. So the changes were as follows. The first change was to replace imatinib and dasatinib with ponatinib, because the French had shown that 3/4 of the relapses were with the T315I mutation, which was resistant to imatinib and second-generation TKI. The second change is shown in the middle, comparing blinatumomab to intensive chemotherapy. It was shown that blinatumomab is superior, so we used blinatumomab instead of intensive chemotherapy. And the third change was shown on the right, where we increased the intrathecals to 12 because the patients were living longer and having CNS relapses, and more recently to 15 intrathecals because we removed the high-dose Ara-C. So this is today our regimen across the board in Philadelphia positive ALL, and I'll show you one modification in the patients with a high white cell count. So we use ponatinib 30 milligrams, not 45 milligrams. We use the blinatumomab with the induction, not 3 months later. So you use it for 4 weeks on, 2 weeks off for 5 cycles. And we start the blinatumomab only after the white cell count is down to less than 5,000 to avoid the cytokine release syndrome. And you do this by starting ponatinib by giving a bit of vincristine and steroids. Once the patients are in complete molecular response, the ponatinib is reduced to 15 milligrams, and we continue the treatment for at least 5 years of PCR negative, NGS negative, and I'll emphasize why I'm saying PCR and NGS MRD negative. The intrathecals are now 15. So this is the update in the first 85 patients. Remember, ponatinib 30 milligrams reduced to 15, simultaneous induction with blinatumomab, 15 intrathecals. We have a median follow-up of 2.5 years. Only 2 patients were still NGS MRD positive and went to transplant, and the 3-year survival is 89%. We are seeing relapses, and these are mostly in patients who start with a high white cell count over 70,000. On the right side, I show the expanded 5-year survival. So it's still at about 90%, which is something amazing. Now, what we also noticed is that when we looked at our patients with Philadelphia positive ALL in remission, we noticed that some patients were NGS MRD negative at 10 to the minus 6, but they remained PCR positive at 10 to the minus 5. And this happened in about a quarter of the patients. A quarter of the patients were NGS MRD negative, PCR positive, but the PCR positivity did not matter. So the survival of NGS PCR negative and NGS PCR positive was the same. So the PCR signal was not coming from the lymphoblast. It was coming from myeloid cells. What is the implication for this? The implication is in those patients who are like this, we don't have to transplant them, but we cannot stop the TKI after 5 years. They have to continue for a longer period of time. The other finding is what I mentioned, patients who had a white cell count over 75,000 at the start were the patients at high risk of relapse. And this was not related to the Icarus Plus. So what we're going to do now is in the patients with a high white cell count, we're going to reintroduce methotrexate Ara-C at 50% of the dose. Now, the Italians, after they did their first study with sequential dasatinib blinatumomab, they had a 2-arm randomized trial of ponatinib blinatumomab versus imatinib low-intensity therapy. At the last ASH meeting, 2024, they reported on those 133 patients in the ponatinib blinatumomab arm, and they showed results identical to ours. Some relapses, the rate of allogeneic transplant went down from 50 to 12%, and the 2-year survival looked very good at about 95%. So there were some deaths from relapses and induction mortality. At this ASH meeting, a month ago, they updated the results of the randomized trial, ponatinib blinatumomab versus imatinib chemotherapy. So 236 patients were randomized 2-to-1 to ponatinib or imatinib plus chemotherapy. And the endpoint was the 70-day after 2 or 3 courses of chemotherapy. That was the primary endpoint. They showed a complete hematologic response rate, which was better with ponatinib, 94 versus 79%. And MRD negativity by flow cytometry was also higher with ponatinib. And the 1-year event-free survival was also higher. So hopefully now people will move into ponatinib blinatumomab as a good standard of care. Now, ponatinib is toxic. So I saw at this ASH meeting, 2025, and this was actually published in Leukemia also, a study of olverembatinib, venetoclax, low-dose chemotherapy. And this was in 80 patients. And they reported a complete molecular response rate of 62% and 1-year survival rate of 93%. So olverembatinib is a third-generation BCR-able tyrosine kinase from China, which is as potent, if not more potent than ponatinib, and it is much less toxic. So now at MD Anderson, we're going to do studies with olverembatinib blinatumomab. They used it with venetoclax, so that's a different twist to that. Now, some people may say, well, we still like the transplant, and what are the results if we induce the patients with imatinib low-intensity therapy and then take everyone to transplant? And this is what the Germans did in 174 younger patients under the age of 55 who received imatinib and low-intensity chemotherapy. Then all of them were transplanted. At the last ASH meeting, the Germans reported that the 3-year survival is 76%. So it's much worse than what we're reporting with the non-chemotherapy regimens, be it dasatinib or ponatinib blinatumomab. And that's because even in the younger patients, there's a 16% mortality from allogeneic transplant. So we should try to avoid it as much as possible. Another question is, can we stop the TKI therapy after 5 years? And here I show data in 14 patients from our institution who stopped therapy because of toxicity, recurrent pleural effusions, arterioveno-occlusive events, pulmonary hypertension, pancreatitis. And what we showed is that if the patients were PCR and NGS-MRD negative for 5 years, this is the curve in blue, those patients do not relapse. So they are behaving like chronic myeloid leukemia, but instead of 2 years of complete molecular response, you should continue for 5 years of a complete molecular response. So the patients who are NGS-MRD negative, but PCR positive, when we stop, and there were 3 of those, they relapsed by PCR, but they did not develop ALL, and neither did they relapse enough to develop CML. We restarted the TKI, so we don't know whether, if we had not restarted, whether these are the patients that might develop later on chronic myeloid leukemia. So for the high white cell count patients, in order to prevent the CNS and systemic relapses, we're reintroducing in course 3 and 4 methotrexate at 50%, 500 per meter square, Ara-C 1 gram per meter square instead of 3 grams per meter square. And then the blinatumomab starts on day 5 for 2 weeks. We do 2 courses. So the blina is 4 weeks. So that makes up for 1 course of blina. So ultimately, even though you have 6 courses, the total days of blinatumomab is the same. And so far, we have not seen relapses in the patients with a high white cell count. So on the left side is the survival of Philadelphia positive CML at our institution. 5-year survival increased from 10% to about 90%. On the right side is the experience by the Italians who followed the same strategies and are showing the same results. Next, I'm going to talk about pre-B-ALL, so Philadelphia negative B-cell ALL. And this is where I'll show you that the therapeutic revolution is happening because we are introducing the 2 antibodies, blinatumomab that targets CD19, and it is a bispecific T-cell engager, inotuzumab, an antibody drug conjugate that targets CD22. And possibly in the future, we're going to use the more potent CD20 BiTEs, bispecific T-cell engagers, which are approved in lymphoma instead of rituximab. On the right side, I show the revolution with the CAR T cells, because now we're not going to use them in refractory relapse active disease, but we're going to use them in remission. So the first piece of information that came about that those antibodies were highly effective were the single-arm trials and then the randomized trials comparing blinatumomab versus standard of care intensive chemotherapy and inotuzumab versus standard of care intensive chemotherapy. Both of these randomized studies showed that blinatumomab and inotuzumab more than doubled the CR rate, and they improved the survival as single agents in refractory relapse ALL. So they were FDA approved for the indication. But I think this is the wrong use because you're using a lot of money and you're not curing too many patients. So at MD Anderson in 2010, we modified the treatment in the younger patients up to the age of 60 in several ways. The first one was we reduced the number of intensive chemotherapy courses from 8 to 4. The second modification was to replace the other 4 courses of intensive chemotherapy with 4 courses of blinatumomab. So immediately we halved the intensity and duration of chemotherapy, which has not been done yet by any other group in the cooperative trials in either adult or childhood ALL. And the third modification is we reduced the POM from 2.5 years to 1 year and 3 months. Later on, inotuzumab was offered as a free drug, so we added it, but you have to be very careful. You cannot use inotuzumab at the FDA-approved dose of 1.8 milligram per meter square as a single dose per course, because then there's a lot of myelosuppression and veno-occlusive disease. So what we do is fractionate the inotuzumab, 0.3 milligram per meter square on day 1 and day 8. And if the platelets are low on day 8, we delay the inotuzumab dose. We do this for 4 courses, 2 courses with the methotrexate Ara-C, 2 courses with the blinatumomab. The total dose of inotuzumab is 2.4 milligram per meter square. We use ursodiol prophylaxis, and this reduces the incidence of veno-occlusive disease even when they go to transplant down to 2%. So these were the 4 modifications: shortening the intensity and duration of chemotherapy, adding blinatumomab sequentially, adding the inotuzumab, and reducing the pump maintenance. And these are the results that we published and updated in AJH a couple of months ago. We have treated 75 patients. The CR rate is 100%. NGS MRD negativity 76%. In contrast to the cooperative studies in France, our 60-day mortality, because we have a lot of experience with this, is still 0%. A third of the patients with high risk, like KMT2A, go to transplant. And for the first time, we show in adult ALL up to the age of 60, a 5-year survival rate, which is as close as possible to childhood ALL. It's about 85%. When we added the inotuzumab, so when the 2 antibodies were given, blina and ino, the red curve shows an improvement in the relapse-free survival and overall survival. And on the right side is the comparison of the hyper-CVAD inoblina to the hyper-CVAD of ofatumumab. So the 5-year survival is improving from 60% to close to about 90%. What we have not published is the update now in 100 patients, very similar data. 5-year survival in red, close to 90%, as close as possible to childhood ALL, an improvement with the 2 antibodies, and the comparison to the historical data. And at this ASH meeting, we did a propensity score matching because we're not going to do a randomized trial. Other people may do that, where we compared the hyper-CVAD blina ino to the previous hyper-CVAD, and we showed by matching the patients that the 5-year survival increased from 63 to about 90%. So these are very good data, and other groups are doing the same, mostly with blinatumomab without the addition of inotuzumab, except for the bottom one in older AML, which I'll show you later. So this is a study that was published by Dr. Litso, and so far it's the only randomized study in adult ALL, but it had an unusual design. What they did is give intensive chemotherapy for 3 courses, and only the patients who became MRD negative were randomized to blinatumomab for 4 cycles versus chemotherapy. So when you look at the design and implementation of the study, you find that of the 488 patients who started, only 1/2 of them became MRD negative and were randomized, and their 5-year survival improved from 55 to about 85%, which is exactly what I showed you in our study. But also they showed that 4 cycles were better than 1 to 2 cycles, which was better than nothing. So are there other studies like this? So at this ASH meeting, Dr. Boissel from France updated the results with blinatumomab consolidation in high-risk frontline adult ALL. And this was not a randomized study. This was a study where they added blinatumomab in the high-risk patients, and then they compared them to the patients who did not receive blinatumomab. And they showed that the categories were comparable. And with the addition of blinatumomab, the 3-year disease-free survival improved from 48 to 70%. And this study underperformed, I think, but that's perhaps because they used only 3 courses of blinatumomab rather than the 4 to 7 courses as we have done. It's also important that the benefit in the high risk did not expand to KMT2A. So KMT2A in adult ALL still requires allogeneic stem cell transplantation. So then this brings up the question, how many courses of blinatumomab are needed? Do we need 1 or 2 or 5 or 7? So first I'm going to show you the data in infant ALL. So infant ALL under the age of 1 year is mostly KMT2A, so translocation 11q23. And the first study came from the Netherlands, where they reported on 30 infants that received chemotherapy and 1 course of blinatumomab, only 1 course of blinatumomab, and they showed an improvement in the 2-year survival rate from 55 to 90%. There was also a similar study from the UK at the last ASH meeting, also in 27 infants. In this study, the chemotherapy was reduced significantly by 50 to 90%, and blinatumomab was also given for 1 course, and the 2-year survival was 93%. So identical data. And both of them are now increasing the blina to 2 courses in infant ALL. Now, this is the study in childhood ALL. So in that study, they took the patients who were standard risk, and they randomized them to chemotherapy plus or minus 2 courses, only 2 courses of blinatumomab. And they showed that the 4-year disease-free survival rate increased significantly. It was already very good, but it went from 87 to 95%, and the CNS relapse rate decreased. So then their argument is maybe 2 courses is enough, but they did not reduce the intensity of the chemotherapy as we have done because their cure rate is very high. In the LITSO study, Dr. Luger went back and looked at the same data, and she looked at the number of courses of blina delivered. So on the left side is the overall population, which I showed you earlier. In the middle is the control versus 1 to 2 cycles. So they said no difference, but of course there is a difference with the long-term follow-up. And then 4 cycles was better than 2 cycles. So in adult ALL, I think at least 4 cycles are needed. At MD Anderson, we're doing 7 cycles. Here I showed that the KMT2A rearranged ALL is still adverse with any kind of therapy. So this is the data with the Brexucel, so the CAR T cell therapy. And what they showed with the CAR T cell therapy is that the patients who received CAR T cell therapy improved their outcome if they were TP53 and CRLF2. But with the KMT2A, they did not improve their survival. So KMT2A remains an adverse prognostic group that we cannot salvage with the chemotherapy blinatumomab, and we also cannot salvage with CAR T cells. You still need allogeneic transplant in these patients. So what are the investigational options in KMT2A? I showed you the 2 studies from the Netherlands and the UK, where the results in infant KMT2A were very good, but the results in ALL are still very poor. So the new studies are now incorporating the menin inhibitors with blinatumomab. So the trials at MD Anderson are now going to use blinatumomab inotuzumab with a menin inhibitor, or the mini CBD blina menin inhibitors, followed by CAR T cell and possibly transplant. So what do we do in patients that you induce into a remission and they are MRD positive? So in this subset, we know that there's already a regulatory approval for blinatumomab. So blinatumomab can be used across all patients and across all age groups based on the regulatory approval. So what you see historically is children who were MRD positive had a worse survival, which is shown in the right upper curve, but the 10-year survival is 55 versus 90%. In adults with the same findings, the 4-year survival is only 20%. So this is where at MD Anderson we use blinatumomab, but not for only 2 courses like the Germans did, but for 5 courses. And we showed that most of the patients achieve MRD negativity. And now, so this is the update of the data at this ASH meeting. What we show is that the 5-year survival has gone up to about 60% from 20%. And when we use it for minimal disease, so the Germans has used the blinatumomab only in patients who were positive at 10 to the minus 3. We have used it in any case of NGS MRD positivity. And we show in those patients that actually the 10-year survival would be very high, about 75%. And on the right side, we show that the transplant does not improve the outcome in the patients that we transplanted simply because of the transplant-related mortality. So this is where we're going to do CAR T cells instead of allogeneic transplant. We have similar data with inotuzumab for patients who are MRD positive. So we did this in 37 patients, and we showed the same findings that the 3-year survival rate goes up to 60%. There's no benefit from transplant. And the results are better if you do this in first remission as opposed to later remission. So now we have many tools for patients who are MRD positive, including CAR T cells, as I'll show you later on. So what about older patients with ALL? So in older patients, if you use only intensive chemotherapy, the results are terrible. You can cure about 10 to 15% of the patients. So in the older patients, we use the mini CBD with inotuzumab, and we later added the blinatumomab. So it was in reverse to the younger patients, simply because Pfizer and Amgen gave us the 2 drugs for free at different periods of time. And we showed that immediately we improved the 5-year survival rate from 20% to about 50%. And this was done by many others. And here there's more variety. Some people used inotuzumab, others used blinatumomab. So let me show you some studies that evolved. So Dr. Chevalier, this is the French group, and this was also done by the Germans, used a pre-phase of vincristine steroids. Then they used fractionated inotuzumab for 2 courses, and then 5 courses of intensive chemotherapy. And what they showed is an improvement in the 4-year survival rate to 41%. So similar to the studies that we have done. And they see some veno-occlusive disease, but it's not that significant. Another study that was published in JCO also used inotuzumab as an induction. And this is where the study shows the potency of inotuzumab as a single agent, because the CR rate after inotuzumab was 85%. After adding blinatumomab, it went up to 97%. And this was in older patients. And they reported a 3-year survival rate of 60%. So maybe in the future, we can do the same design, but use the CAR T cells instead of allogeneic transplantation in remission. So I keep talking about the CAR T cells, but the question is, where's the data that the CAR T cells can be useful. So this is the first set of information from the ASH meeting by Dr. Aldos from City of Hope, where he took 20 patients who were over the age of 55, who were induced in a remission with any chemotherapy, and then he infused them with CAR T cells, and he's reporting a 1-year progression-free survival of 90% with minimal toxicity. What about what do we do in relapse? So here I show you that in relapse, 2 studies from the UK and France in about 1,000 patients show that in adult ALL, once you have a first relapse, the potential cure rate with intensive chemotherapy is only 7 to 8%. So we have used the same regimen of mini-CVD inoblina in relapse, and we have treated 125 patients. The overall marrow response rate is 83%. We have seen veno-occlusive disease at the beginning, but after fractionating the inotuzumab and adding the blinatumomab sequentially to delay the inotuzumab from the transplant, and by using ursodiol, the incidence of veno-occlusive disease went down to 2%. And what we see now is a 5-year survival rate of not 8%, but 40%. In the middle is the 2 antibodies with a 3-year survival rate of 60%. And on the right is the lack of benefit from transplant because of the mortality. So what we're going to do is use CAR T cells instead of the transplant. Now I'm going to show you 2 more pieces of information which are important. So as you know, the blinatumomab is given at 28 micrograms daily for 4 weeks, so a continuous infusion. We have developed a subcutaneous blinatumomab for the matter of convenience, but then we kept increasing the dose and we realized that we can give 5 times the dose of the subcutaneous blinatumomab. And in 88 patients that we treated in a multi-institutional trial, published in Lancet Hematology by Dr. Jabbour, we find that the CR rate is close to 90%, much higher than what I showed you with IV blinatumomab, where the CR rate was about 50%. But more importantly, I showed you with the IV blinatumomab that the median survival was 7 months. Here, we don't have yet a median survival. The survival at 1.5 years is about 60%. The price to pay is a higher incidence of neurotoxicity. So now what we're going to do is see how we can alleviate the ICANS, perhaps by giving a dose of steroids with the subcutaneous blinatumomab. The second thing which I encourage you to try to test and incorporate in Colombia as soon as possible is what we call the dose-dense mini-CVD inoblina, which I refer to as the BRIC regimen. So B is blinatumomab, R is rituximab or a CD20 antibody, I is inotuzumab condensed with chemotherapy. So here, instead of doing the blinatumomab sequentially after the chemotherapy, we are adding it on day 5 for 14 or 18 days with every course of chemotherapy for 6 courses. And then in the first 4 courses, we do inotuzumab fractionation. Today, we're giving pump maintenance, but I'll show you that the CAR T cell consolidation may be as good, if not better. So we have treated 25 patients in relapse. All of them achieve a complete remission. NGS MRD negativity 95%, which is amazing because these are all patients in first relapse. And now we have a 2-year survival of 75%. On the right side, remember the historical data is a 3-year survival of 8%. The red curve is mini-CVD inotuzumab. The blue curve is mini-CVD inotuzumab blinatumomab. And the green curve is the dose-dense mini-CVD inoblina, followed by the CAR T cells. So now I'm going to argue that the CAR T cells are best used in minimal residual disease. So this is the data from Obi-cell. This is the CAR T cell from England. And what they showed is that the drug is very safe because they fractionate the dose according to the tumor burden. So if the tumor burden is high, they give only 10% of the CAR T cells on day one, and they give 90% on day eight. If the burden is low, they give 90% of the CAR T cells on day one and 10% on day eight. So they report a high CR rate. But what caught my attention is what the patients who received the CAR T cells in minimal residual disease have a 3-year survival rate of 70%. These are patients who had already a relapse. So that's why I believe that inducing the patients in a remission before infusing the CAR T cells is a better approach. This is in Philadelphia positive ALL. So what the investigators from China did is they induced the patients with olverembatinib, vincristine, prednisone, and venetoclax. And then, so this is Philadelphia positive ALL. And then they gave them the CAR T cells. And with a median follow-up of a year, all the patients are alive and disease-free. So this argues that we can use the CAR T cells in consolidation and perhaps improve the results of what I've shown you already before. And this is CAR T cells for CNS relapse. So this is data from UPenn, where they took 42 patients who had CNS leukemia. These are children. And they gave them triple intrathecal so that most of them had minimal disease, no CNS3. And then they gave them CAR T cells. And what they showed is the CNS disease-free state persisted in 90% of the patients after 2 years. So the CAR T cells are not only useful for active disease and for minimal residual disease, but they are also very useful in the setting of CNS leukemia and for CNS leukemia prophylaxis. It's very important to know that when you give the CAR T cells, there's mortality. 50% of the patients who receive CAR T cells for active disease and who die from infections. And many of them are COVID or bacterial or fungal. So it's very important to do a lot of prophylaxis. So this is what we do post-CAR T cell prevention. We give Bactrim to prevent PCP. We give Valtrex to prevent viral infections. We revaccinate all patients 6 months after the CAR T cells. And we monitor IgG levels. And if they go below 400 and they have infections, we replace with IVIG on a monthly basis as needed. So thank you for your attention, and I'm happy to answer any questions.
Thank you, Professor Kartaryan, for this conference. We are very excited with this update and all the slides and presentation and studies presented by you. And now we are open the discussion with the professors and the staff. So,
but can to present the cases
okay.
first one?
Okay,
Yeah.
we prepare short cases in our sitting, in our Colombian context. We don't have all the authorizations and access of all technology as yours. And the idea is to discuss real cases and our challenge in our country. So please confirm if you are see my slides.
I can see your slides.
Oh, perfect.
Go ahead, Dr. Kwak.
Oh, perfect. We are from Cali, Colombia. Cali is located in the southwestern region of the country, and this is our hospital. We are the biggest in the country, so we have a big responsibility in our country. So the first case is a patient male, 43 years old, comorbidities, hypertension and obesity. And he attended our institution because he had anemia and thrombocytopenia. So we performed flow cytometry in peripheral blood, and we found 26% of blast for ALLB, common phenotype CD20, 77%, and CD22, 78%. We don't have the access for all patients for do NGS test. So we choose in our institutional protocol RT-PCR for BCR ABL that was negative, FISH for KMT2A negative, and his karyotype was normal, and the study of CSF was normal too. So he was a young male patient, so we decided to study early his brother that has 51 years old and HLA 5 to 10. So the treatment that we have in our protocol is the PITIMA, the Spanish group protocol. And we did the induction phase, and the patients, the MRD showed complete response. Then we continue with the consolidation phase, and then a second consolidation, but the MRD was 11% of blast, and the CSF study shows that positive. So we decide rescue chemo, immunotherapy, excuse me, with blinatumomab, but the patients present a cytokine release syndrome, and the MRD was 33% of blast. So we decide a chemo rescue regimen with Iroflac, and the blood count in peripheral blood showed 93% of blast. So we decide to start it in inotuzumab, and the peripheral blood count showed 66% of blast, and different infectious diseases complications as fungal sinusitis. So we decide to continue in palliative care and best support care, and the patient passed away the next day. So we have three short questions for you. The first one was, what treatment options do you consider for salvage chemo in ALL?
So
Yeah, of course.
So the first question is, what's good salvage chemotherapy? I think the FLAG-IDA is very good. As I've shown, what we're doing now is the dose-dense mini-CVD inoblina. So even though the patient has failed blina as a single agent, has failed ino as a single agent, when you do that combination, some patients respond. But also, when we do the FLAG-IDA, we try to add venetoclax, and also we add some vincristine, some steroids, and asparaginase. So this is what we call the kitchen sink approach in the patients who fail. So one thing that you may want to start considering doing is if you can convince the companies to give you the free blina and ino, is to do the dose-dense mini-CVD inoblina followed by the CAR T cells. In this patient, I think you've done everything correctly. I do not see any adverse features, so it's possible that maybe if we had done additional mutation analysis or optic genome mapping, we would have seen some translocations which are very adverse, maybe KMT2A that was missed by cytogenetics. And the two things which may be missing from here is the use of CAR T cells, the use of venetoclax, and the use of combinations, even though a patient has failed a single agent approach. So you've done everything optimally in the context of the availability of the drugs. And I really don't know why the patient was so resistant. So let's see your second question.
Doctor, a question. Do you think that maybe if we combine in the second course blina with minihypercibat, is better the result, or maybe give a second course of blinatumomab is a good option. In Colombia, it's not possible to give CAR T cell therapy. We only have blinatumomab, inotuzumab, and Flagida. It's impossible to give venetoclax for our patient. But what do you think? Do you
So
think
I
it's
think you
better
are
combining
right.
blina with it?
So I think you are right. That maybe you could have used the blinatumomab immediately after the induction. So I showed you with Dr. Litzo, they do 3 courses of chemotherapy, and so they lose half of the patients. So this patient has behaved the same way where he was lost after the second consolidation. So it's possible that if you had used the blinatumomab earlier, you may have done better. The other thing I suggest is with the blinatumomab, used it for only 14 days. And I guess that's because of the cytokine release syndrome. What you may want to do is rather than discontinue, to give steroids and to try to restart at 5 or 9 or 15 micrograms instead of discontinuing. Many of the patients then do not have the cytokine release syndrome. And the bad thing is really not the cytokine release. You can always give steroids and interrupt and use a lower dose. It's mostly the neurotoxicity that is usually a problem.
Thank you, doctor.
Thank you. So this second question is about the diagnosis of CNS involvement. In your setting, what do you use? The cytochemical analysis, cytology, flow cytometry, what is the best, or you only use one?
No, actually, we send the specimen now for the cellular differential, the cytospin, and we're starting to do flow cytometry because we noticed that some people who are negative, but they are flow cytometry positive, and they tend to relapse. So actually, we are doing all 3, the flow cytometry, the regular cellular analysis, and also the cytospin. I have to tell you one thing also, in patients who get blinatumomab or CAR T cells, when they get neurotoxicity, sometimes you do a spinal tap and you see lymphocytes. And the pathologist sometimes says, this is ALL. Actually, they are mostly T cell lymphoproliferative. Can you still hear me? Do you have any problems? No, right?
No.
So be careful if you have a patient with neurotoxicity on blina or CAR T cells and you do a spinal tap, make sure to tell the pathologist that the patient is on blina or CAR T cells so that they are aware that those lymphocytes are not ALL. They could be polyclonal T lymphocytes related to the therapy.
Okay, thank you. So Professor Dominguez, hands up.
So do you want to show me the
Hello?
third question?
Yeah, but Professor Dominguez.
Dr.
want
Cantarne,
to-
can you hear me?
Yeah, I can hear you. Go ahead.
So first of all, thank you for your amazing presentation. I have a question about, as we live in a resource-limited country, what's your preference to go for immunotherapy in the relapse patient? Do you prefer inotuzumab, blina? And what clinical variables you take on account to make that decision? Right now we don't have the approbation to go for a combination of these 2 medications, so we have to choose between one or the other. So that's
So do you
my
have
question. Thank
do you
you.
have CAR T cells in Colombia, Dr.
No, we don't have access to CAR T cells. We only have immunotherapy with blinatumomab and with inotuzumab, and also we have chemo as in the relapse settings with IDOFLAG or FLAG-like chemotherapy.
So do the authorities prevent you from using chemotherapy with either Blina or Ino? Because you
No,
can, okay.
it's approved
Can
in the
use.
relapse settings. Right now we have the recent approval of Blina in the first line setting, but it's only about, I think, a month ago. So in the relapse setting, we have to choose between Blina or Ino. So my question is, in your experience, what are the like the clinical variables that you take in consideration to decide between Blina or Ino in a patient who is already relapsing on chemo or apetema or something like that protocol, or I perceive that?
So what I would do is rely on what the patient has received. So if you're saying in the front line, the patient has received some form of Blina, then I would do the dose-dense mini-CBD with inotuzumab. And if the patient has not received Blina, then I would do the mini-CBD with blinatumomab starting on day 5 and try to repeat several courses and then take the patient to transplant if you don't have CAR T cells.
Doctor, is important for you the count of blast for select inotuzumab versus blinatumomab?
The threshold of blast level is important for choose one or not?
No. I think on average, and what you've seen from the slides, is that inotuzumab is more potent, but also it's a bit more toxic. And if you're planning to take the patients to transplant, you have to space the last inotuzumab dose from the transplant by 2 months. Otherwise, the incidence of veno-occlusive disease in children has been reported to be 20%. In adults, it's about 10%. I don't know why the difference. So if you choose inotuzumab in the salvage in combination, do not use it as 1.8 per meter square. Use it as 0.3 per meter square fractionated with chemotherapy. With inotuzumab, do 4 courses with chemotherapy and inotuzumab. Do 4 courses. Then, if you can sneak 1 course of blinatumomab before the transplant, that will be good. You improve your remission, and you delay the transplant so that the incidence of veno-occlusive disease will be lower. But it's important to fractionate the inotuzumab. Do not go over 2.4 to 2.7 per meter square. Use ursodiol 300 per meter square, and then do something between the last inotuzumab dose and the transplant. Perhaps 1 course of blinatumomab, because the patient is already in relapse. So even if he has remission, the NGS may be positive, and you can use this with the authorities to give 1 course of Blina and then move to the allogeneic transplant. Is that feasible in Colombia? If you like, try to avoid the landmines in this way, because you can design a study like this: mini-CBD, 4 courses, then Blina 1 course, then allogeneic transplant. And it will be all approvable because you can demonstrate NGS MRD positivity across the spectrum. Do you do the NGS MRD, or you do not have it yet in Colombia?
Only flow cytometry, doctor.
Okay. And the flow cytometry is at 10 to the minus 4, or you can make it at 10 to the minus 5 or better?
We did flow cytometry in all the steps of the process. Sometimes if the patient have the money, they could pay the NGS, but it's not common here in our
But it's a qualitative NGS, it's
So-
not a quantitative.
Yeah, exactly. And Dr. Dominguez?
Thank you for your answer. And I have another question, and is if you think there is a place for chemo rescue with IDAFLAC in a patient who have not received in the first line setting Blina or Ino. So it's a patient that is naive for these 2 medication and is in relapse settings. Do you think that nowadays there is some place for a patient to take a chemo rescue regimen, or you go for?
So if they are and blina naive, I would prefer one of the two antibodies with chemotherapy. And also, if you use the flag IDA, consider adding also vincristine 1 milligram on day 1 and 15, decadron 20 daily for 4 days on day 1 to 4, and maybe 1 dose of pegylated asparaginase, flat dose 1,000 units on day 5. This approach, combining more chemotherapy, will probably give you a better CR rate if you're planning to get the patient to transplant. Now, it does cause more myelosuppression, so make sure that all the patients are on Livoquin, Valtrex, and an azole, either posaconazole or voriconazole. And when you use the azoles, you have to stop them when you give the vincristine. You stop them the day before, the day of the vincristine, and the day after, because if you do not do that, they develop more neuropathies, including bowel stasis and obstipation.
Okay, thank you.
Can continue with the next question, doctor.
So, what additional treatment options do you consider when patient presents CNS involvement? Is intrathecal chemo the only approach? You chose the scenario with immunotherapy. So, what do you think?
So today at MD Anderson, if we have a patient with de novo CNS disease, we do triple intrathecals until they are negative, then so twice a week until they are negative, then weekly for 4 times, then every other week for 4 times. In the meantime, we prepare for 2 things, craniospinal radiation as definitive therapy and the consideration of CAR T cells. In Colombia, what you can do is the triple intrathecals until they are negative, and then consider craniospinal radiation therapy as a more definitive therapy. So we have abandoned craniospinal radiation therapy as either prophylaxis and mostly as treatment because we thought the triple intrathecal is good. But the triple intrathecal on its own in de novo CNS disease can cure the CNS disease, but in relapse, it cannot cure it. So you have to do the craniospinal, and at MD Anderson, we do also CAR T cells. So the intent is still curative, even when there's CNS relapse, either at diagnosis or later.
Okay, perfect. So we have 5 minutes to finish this meeting. So we have time for other small case and other question or no?
Sure.
Yes.
Go ahead.
Okay.
We are limited for your time, Dr. Kartagian. If you can answer all our questions, we are very happy.
Thank you.
Go ahead.
So we here, as I show it, we have protocols based in Spanish study. So in MD Anderson, do you use L-asparaginase or asparaginase only? So
No, so we use the
No,
pegylated
T-cell.
asparaginase. We use it mostly in T-cell ALL as a consolidation, and we use it in ALL relapse like in the previous case. We stopped using pegylated asparaginase in the frontline setting, except in T-cell ALL.
okay, thank you. The other question is after blinatumomab therapy, the first cycle, as salvage therapy, patients with MRD with 0% with available donor, next strategy, what is better? Blinatumomab second cycle versus pass to hematopoietic stem cell transplantation.
No, I would probably do at least 2 to 3 courses of blina, and then I would do the allogeneic transplant, because this way the potential cure after the transplant will be better than with only 1 course of blina. And this is where the NGS MRD will help you, because if there's a lot of disease, you would want to go with the 2nd and 3rd course of blina before the transplant to increase the chance of the transplant success rate.
Okay, and our final questions is related with Philadelphia-like scenarios. You know that in Latin America, we have more prevalent cases of this type of leukemia. So if we review the available studies in clinicaltrials.gov.com, so there are few studies focusing this population. And in the case that we are explored with NGS, we found some of these variants in our population. So,
Yeah, so let me
is
tell
the
you
treatment?
what we
Yeah.
do for the Philadelphia like or the BCR able like. If they
Yeah.
have able class fusions, so the ones that you're showing, we treat them like Philadelphia positive ALL. So we use a BCR able kinase inhibitor with blinatumomab, or if you want with chemotherapy, and then you can consider a transplant. But usually we treat them like Philadelphia positive ALL, and we monitor them by PCR and NGS. The one exception is PDGFR beta, where that entity responds better to imatinib rather than ponatinib. So for all the able class fusions, I would use the more potent BCR able kinase inhibitors like ponatinib or dasatinib. In the PDGFR beta fusion, I would use imatinib with the chemotherapy. Now, all the others, so they are CRLF2 overexpression with or without JAK2 mutation. If there is a JAK mutation, these patients do worse. So I would induce them with whatever therapy. So at MD Anderson, hyper-CVAD, inoblina, and then monitor by NGS. But many of the JAK2, we send them to transplant. If they do not have a JAK mutation, only CRLF2 overexpression, so regular Philadelphia-like, then we do not send them to transplant if they become NGS MRD negative. We just continue the management.
Okay, thank you, Professor Kartarjan, for your time.
No, one question, one last
Final-
question,
the-
final question.
So sometimes in our scenario, we have a test with our results shows 0.0001%
In
in
BCR.
BCR. So what do you think about?
In this case, it's necessary to treat with ponatinib or imatinib, any TKI, or if it's low to 0.5, we don't standard of care continue with the treatment with TKI.
So you're talking about a diagnosis or after therapy in Philadelphia?
No, diagnosis,
For
doctor.
diagnostics in
Now, at
Philadelphia.
diagnosis, there's a lot of false positivity. So if you have a PCR of 0.001%, that's probably a false positive. I
Okay.
would not consider it true positive unless it's over 0.05% repeated twice or three times.
What is your point of course?
The cut
cut.
off
Put up.
for your
Probably 0.05%.
okay.
For
Or
a
0.
diagnostic.
Okay.
Yeah. Oh, nice. Thank you.
Thank you, Dr. Kartarjan, for your presentation and your answers. That's very important for us, your reports, and we
Invite you in future academical section for discuss cases or updates on in our activities.
Thank you so much,
Sure.
doctor.
Have a
My
good day.
pleasure. And if you have difficult cases, just email me. And you can
Okay,
share
thank
the
you.
slides with the group.
Okay, thank you. Thank you.
Thank
Have
you,
a good
doctor.
day.
Take care. Bye-bye.
bye-bye.
Querido, ¿no? Se quedó 2 horas con nosotros. Qué lindo. Qué bacano. El que estamos en pañales, ¿no?
No.
No tenemos nada. Cuando él decía, no, pues primera línea y no oblina.
No, plagiaba Benito, claro.